as we have a 24-hour hotline, as well as the ability to go out and provide face-to-face evaluations to patients who may be in crisis in the community. The screening law itself, in regards to patients who may need that face-to-face evaluation, only applies to patients who are 18 years or older. I'll go in a little more detail, the difference between adults and minors, a little later in the presentation. So part of our 24-hour crisis hotline is, we do also provide phone assessment and crisis intervention over the phone to determine the most appropriate intervention, which could be just providing some referral information, any type, some patients call in, they may need more emergent voluntary outpatient services or linkage to different community supports and assistance. And we can provide a lot of guidance and kind of information on what resources might be most appropriate for whoever's calling. If someone is in crisis and they want a voluntary, they want to voluntarily go to the hospital, we can take that information. We can call ahead to the hospital of your choosing. We can let them know the clinical information and that the fact that that the patient's coming, and kind of really just to provide support throughout that process, and then continue to follow up with that hospital. And any family member who maybe gives us that alert, or a patient who gives us that alert, the family members can call us just to find out what that final result is. It is possible to do that. If we do get a call where someone is experiencing a psychiatric crisis, and they're not voluntary for services at that time, or their symptoms are so severe that they really don't have the insight or judgment to consent to voluntary treatment, we can provide a face-to-face evaluation. Those services are for patients who are physically located within Bergen County. So if someone lives in Bergen County but happens to be physically outside of Bergen County, we wouldn't be able to provide those outreach services at that time. If we do decide to go out, we can have police come with us. Their role they're really not there for any other reason than to provide safety and security during the outreach. We really have a great program in Bergen County for a crisis intervention team and training for the officers and community providers who all come together. So there really is a strong dedication to making sure that when police are responding to these type of situations, they're really as prepared and sensitive as they can be in those situations. And the screener is going to kind of work as the quarterback, who's going to kind of try to arrange and work with the family, find out what your concerns are, and try to make sure that they are considered during that outreach. So in addition to that, if after we evaluate that patient and it is decided that the patient does need to go back to the hospital, the police are the ones that will assist with having that patient transported to the hospital. It really kind of, we work with them closely to make sure it's done in the most sensitive and efficient way. So when our services are requested, they do have to be face-to-face, or we can do virtual evaluations via telehealth. But it does have to be, we can't do anything over the phone. It does have to be a face-to-face evaluation. And patients, usually when we're assessing for dangerousness, there's 4 categories of dangerousness that we're looking at. So we're looking at patients who may be having suicide. It's danger to self-suicidal, where patients are having suicidal thoughts, thoughts of harming themselves, thoughts of killing themselves, and there's a concern that they may act on those thoughts. There's also a category where we're looking at danger to others. Are they making threats of harm? Are they acting and behaving in a way that might cause, others to be at risk? That we'll kind of ask those type of questions and assess, is there a danger to others? Are they destroying property? Are they destructive at all to their property in the community, or property to their family members, anyone, any type of property? And then we also look into a 4th category, which sometimes, is a little bit harder to assess, and it is a bit of a gray area sometimes, but basically it's danger to self, due to either someone who is not able to meet their basic needs for food, shelter, or essential medical care, or if patients' symptoms are impairing their judgment to the degree that they may be placing themselves at risk of harm, either erratic behavior or concerning behavior. Those are all areas that we might look into. It is possible too that families can reach out. Maybe they're not sure what to do. Maybe a patient has stopped taking their medication and they're more symptomatic, but they're not quite where they would be normally if they were going to the hospital. But a family's concerned about that. They're concerned about, in the near future, could my family member be at risk? You can give us a call, kind of go over the symptoms and discuss it with our screening staff and kind of come up with a game plan. Are there any lesser restrictive interventions that we can explore in the interim? Or, is it time to kind of get screening involved and have an evaluation? When we do our assessment, part of our assessment is meeting with the client, but we also will speak with family members, treatment providers, anyone who is involved in that client's life, to make sure that we're getting all the necessary information we need in order to make an appropriate decision. And we'll do our best to advocate for that client throughout the entire process to make sure that they're safe and they're getting what they need. When someone is calling into the screening center, we have some basic information that there is a lot, sometimes it's difficult if you're feeling that you're in crisis. It isn't always easy to kind of go through those questions, but we have a full assessment that we do have to ask when we have families coming in. So we would need their demographic information, their location, some of their current psychiatric symptoms and safety concerns. Is there any alcohol or substance use that we need to consider, and any current treatment or past treatment that they're involved in. In addition to taking into consideration psychiatric concerns, we're also looking at current medical symptoms and diagnoses, and could their crisis be related to those? Is the patient in a state of delirium as a result of substance use or as a result of a medical condition? And is there a possible medical emergency? We're trained to kind of look at those different situations. There are times that sometimes prior to a screening, we may ask police and EMS to go out to make sure that someone is medically safe before we send a screener. And sometimes EMS can be part of that, where they can take vital signs, they can kind of make their assessment. If we are concerned, we're going to express that concern, but ultimately EMS or police may make a final decision on whether or not that patient is in a medical emergency. If there is a concern that that patient is in a medical emergency, they may be medically transported to the nearest ER, and that might be the intervention at that time that's most appropriate to make sure that their medical concern is treated properly. Sometimes patients are brought to the nearest ER also if they happen to be under the influence of alcohol in a public area, and they can be brought to the hospital by police to be medically cleared and make sure they're safe. And they have to kind of stay there till police feel that till emergency staff feel that they're safe and secure. The other thing that may happen sometimes family members are or clients are experiencing such an acute, disturbance that we're really concerned of imminent risk of harm in that moment. And sometimes police do have to go out before us because they do have that capacity to have a more immediate response. Usually as screeners, we try to get out as soon as possible, usually within a half hour to 15 minutes to a half hour if we have a deployable screener after we finish, the call and decide that that's the most appropriate intervention. But there are times where either we have to send police first or we, may have to wait for a screener. So in those two scenarios, if police do go out first and they determine on their own observation that a patient may need further evaluation in an ER due to safety concerns, they can transport that client to the screening center, which is at Bergen Newbridge Medical Center. And then they would then get further evaluation in the ER. And I can kind of go into a little bit more detail in a minute about what would happen if a patient is transported there. The other thing that may happen, let's say either family members are confident they can safely maintain a patient until a screener is available. Let's say we don't have a screener right away, and maybe multiple hours sometimes, unfortunately, till we have some available. What we usually do with callers is we'll safety plan and, kind of come up with the best possible way to make sure that the patient is safe in the community until we can get a screener out there to evaluate. So those are kind of two scenarios that could happen if we are evaluating a patient and we determine that the patient does need involuntary transport to the screening center for further evaluation, then we would authorize police to assist us with that transport, and they would go to Bergen Newbridge Medical Center for further evaluation and treatment. If they are going there involuntarily, they need to stay at the hospital at that point until they are evaluated by a psychiatrist. And the first step once they get to the ER would be the patient receiving a full medical evaluation to make sure that the patient's medically safe, that there isn't a more emergent medical issue that needs to be treated first. And then once they get that full medical evaluation, and they're deemed medically stable and appropriate for further psychiatric evaluation, then the psychiatrist at the Bergen Newbridge ER will evaluate the patient. At that time, if we've outreached the patient first in the community, we're going to collaborate with the psychiatry at Bergen Newbridge, and we're going to work together to try to come up with the best possible intervention. which could be discharge from the ER, it could be admission to the hospital. Sometimes what we may do at the screening center, if we need further time to evaluate, we do get up to 24 hours to complete our evaluation once we begin it. Sometimes we may place a patient on what's called an extended crisis evaluation bed. And sometimes we do that if the patient needs further medical testing and we want to make sure that there aren't any other complicated issues that are coming up. If a patient is intoxicated, our evaluation is not legal until that patient is deemed sober. So if someone is under the influence of alcohol and is legally intoxicated, per the legal definition, we do have to wait and we will reevaluate if that patient, once that patient is sober in the ER. There are times, so we're talking more of like if a patient comes into the ER on our evaluation, but there are times either a patient will go in on police observation or the patient may go into the screening center voluntarily. At that time at Bergen Newbridge Medical Center, you're really the patient's going to be seen first by the Bergen Newbridge personnel. And then if the psychiatrist at Bergen Newbridge feels that the client's appropriate for involuntary admission to the hospital, then they will refer to our service and refer for involuntary admission. There are times where we're not always on the same page and there, we may be recommending admission to the hospital, but the psychiatrist may feel that they're able to put into place a lesser restrictive discharge plan, and that may happen. I encourage all family members to contact the ER, ask to speak with the evaluating psychiatrist if you really feel strongly one way or the other about what's the most appropriate, intervention for your loved one. It's really important and you can let us know. And again, if we are involved with the evaluation and we've spoken to you and gotten information from you about your loved one's evaluation, then we can later on, you can give a call to us and kind of ask for updates on what's happening with the evaluation, what our recommendation is, and what the final decision was as far as admission, discharge, that type of intervention. So, and that's basically what would happen for an adult going through that process. I know later on we can, if there's further questions about the process, I'm happy to answer all of them. For the difference between minors and adults within the screening law, for adults, we basically we can have that involuntary admission process. Right. The difference for minors, it's not actually covered through the screening law, and the parent or guardian has to consent for us to evaluate the minor. And when we do evaluate the minor, we're only providing a recommendation. So we may recommend that the patient stay in the community and receive outpatient services, or we may recommend that the minor go to the ER and get further evaluation in an ER. In addition to that, perform care, and anyone calling us, if, there are resources that we can provide. If it's not rising to that level where a patient might need those crisis services at an ER or with 262 help, Perform Care manages all child services in New Jersey. So if you call there, you can ask for Children's Mobile Crisis to come out and you can kind of explore with them what other resources, might be helpful prior to kind of engaging that crisis system. In addition to those crisis services regarding, figuring out the most appropriate intervention and level of care for patients. We also have a psychiatrist on staff. So patients who are in the community and they have an appointment with a long-term provider, a psychiatrist, and the earliest appointment is 2 months in advance. But that's just too long to wait for you to get psychiatric services. You can give a call to 262 HELP. We can get all the information, and our psychiatrist, Dr. Kim, can provide short-term psychiatric medication assessment and monitoring until kind of carry through until you get to that long-term provider. There is some capability if someone does not have a long-term provider but wishes to continue with Care Plus and they are really need that emergent service. Sometimes we can work with the patient to kind of assist with that linkage. It's like a case-to-case basis. Sometimes we have to check with our access department to see, if we can do that, but it is a possibility. If you want to continue with Care Plus as a treatment provider, we can try to facilitate that.
Hey, Catherine, sorry to interrupt. I just wanted to double check if you were changing slides because we haven't seen the slides change.
Oh, I have been changing. So so I can see them change, but I guess it's not all right. I apologize for that.
No, that's okay. That's okay. You might just have to press
with police, community mental health providers, schools, so if there's anyone out there that needs us to come speak to their group, or we can definitely do that. And I apologize for the technical difficulty. But basically everything, the slides I went through each slide and kind of went through what we do. All right. And we are 24 hours, so anytime that you call,